All right, team, let's move. We're tackling restrictive cardiomyopathy, the stone heart. Time is critical.
Listen up. The core concept is simple. Restrictive cardiomyopathy, it's a storage war. Plain and simple. All right, here's the blitz. We're talking RCM. Forget thick, forget thin. The walls are stiff. We're talking concrete. That means the heart can't relax, can't expand, can't fill. That right there is your definition of diastolic failure, even when the ejection fraction looks totally normal.
Get this straight. The pump function, the squeeze, is fine. That's why you get a normal EF. The problem isn't the squeeze, it's the relaxation. The heart can't fill. So this is a filling problem, a diastolic problem. Got it? Good.
So what's the number one enemy here? The king of causes? One word, amyloidosis. Burn that into your brain. And the signature, the thing you absolutely have to look for? Apple green birefringence, Congo red stain, no excuses.
Clinically, you're looking for the Kussmaul sign. JVP goes up on inhalation. Don't miss it. Other culprits on your list, sarcoidosis, hemochromatosis, radiation. On the echo, you'll see massive biatrial enlargement. Know the stone, find the cause. Let's go. Okay, that was the blitz. Now, before we proceed into the deep dive, we must pause for a moment. Please understand, this content is for educational purposes for the USMLE and international boards only. It is not and should not be considered medical advice. For any clinical decisions, you must always consult official guidelines and a specialist physician. All right, Sarah, let's transition to our deep dive. I want you to picture this. In RCM, that ventricle, it's like an old, stiff leather bag. It just doesn't want to stretch. So naturally, this creates a huge backup of pressure upstream. With that in mind, tell me, what is the single most iconic physical exam finding we see when these patients take a deep breath? That's got to be the Kussmaul sign, Dr. Collins. You know, normally when you breathe in, the JVP should fall because of that negative intrathoracic pressure. But here, with RCM, or constrictive pericarditis for that matter, the stiff right ventricle just can't handle that extravenous return. So paradoxically, the JVP actually rises. It's a huge red flag for the boards, for sure. Precisely. Now let's circle back to the king of RCM, amyloidosis. The boards absolutely love this paradox. So you get an echo report. It says the ventricular walls are thick, but then you look at the EKG and you see low voltage QRS. What's going through your mind? My mind goes straight to amyloid. It's the classic mismatch. The wall looks thick on the echo, but it's not hypertrophy. It's not more muscle. It's infiltrated with amyloid protein. And that protein, it's electrically dead. It doesn't conduct. That's why the EKG voltage is so low. The signal is just dampened. And to confirm it, the gold standard is still a tissue biopsy. You're looking for that pathognomonic apple green birefringence with a Congo red stain under polarized light. But it's also worth noting, the latest 2023 ESC guidelines really push for non-invasive methods too, like bone scintigraphy for transferrin amyloid and serum-free light chain assays for AL amyloid. Excellent. That's great detail. Now, this brings us to a really critical differential, one that trips up a lot of people on exams. Restrictive cardiomyopathy versus constrictive pericarditis. They can look so similar. Sarah, focusing on imaging, specifically the echocardiogram, how do we start to pull these two apart? Well, on the echo, the big giveaway for RCM is massive biatrial enlargement. It just makes sense, right? The atria are straining against these incredibly stiff ventricles. And if you move on to a cardiac MRI with late gadolinium enhancement, the pattern is key. In RCM, that enhancement tends to be diffuse or subendocardial, in the muscle itself. In contrast with pericarditis, the enhancement is, well, just in the pericardium. Spot on. And let's not forget our other culprits. You've got hemochromatosis, the bronze diabetes, and sarcoidosis, where you have to be vigilant about the risk of sudden heart block. As for management, it's tough. There's no easy fix. You really have to treat the underlying cause, and you use diuretics very, very carefully to manage the congestion. All right, time to lock this in. Let's do the memory chant.
Restrictive is stone.
Diastolic is the groan.
Amyloid is green.
Kussmaul is seen. Biatrial is the echo. Okay, that brings us to our question of the day for all of you out there. Have you ever actually seen a true Kussmaul sign in a patient? I'm curious, was it really obvious, or did you have to look super closely at the neck veins to catch it? Drop your experiences in the comments below.
There you have it. The key takeaways are locked and loaded. Make sure you remember that chant.
Excellent work. So, we've cracked the stone heart. But what about when the heart fails for totally different reasons? Not from infiltration, but from, say, overwhelming stress or even pregnancy. You're going to want to subscribe for that one. Join us for our next deep dive.